Hello everyone, my name is Dr. Samarany. I'm a director of the Advanced Imaging in San Antonio Regional Hospital and a member of United Heart Institute. So I'm here to present you today a talk about advanced imaging, mainly for echocardiogram with 3D, cardiac CT, the novel stuff, nuclear, what's new, and cardiac MRI. And all of those modalities are available in San Antonio Regional Hospital and helps a lot with our diagnosis in multiple domain, helping multiple cardiologists, interventionalists, surgeons, and others. To tell everyone what's cardiac CT, usually coronary CTA. It's a way to see your vessels without mainly doing any invasive procedure. Usually, you know, everybody does an angiogram nowadays in the past, but now non-invasively we can see your plaques, see how much plaques, and I will go into details of how much we can see. And now the technology has become more and more efficient and more kind of accurate, and we can now image the heart in less than 5 heartbeats. And even less, and that technology also it's coming to San Antonio soon, and we can see a lot of things. To start kind of how it looks like, you can see this is an example of an angiogram, but it's not an angiogram, it's a CT, and you can see all the 3 main vessels of your heart, the right coronary artery labeled A, the left anterior descending artery labeled B, and the left circumflex labeled C. Mainly our heart, most of our heart, except some variants, have 3 main vessels. And nice about it is we can see it, we call it rotisserie view, and we can turn the vessel around, and even we can see a minimal plaque, even less than 10% blockage, we can see the plaque and where the plaque is and what's going on. And that helps us a lot risk stratify the patient to see, do we need to do prevention or not? Because all previous tests, you cannot see any plaque, especially the old stress tests that we used to do, cannot see any plaque, only it sees when it's more than 70% because it measures the blood flow. So this is an example of a lesion, and you can see those 2 white dots. Those are calcified plaque, meaning old plaque, and these plaque are in the proximal LAD, the first part of the LAD, which is the middle vessel, as I said earlier, and you can see they're causing approximately less than 25% blockage. But this finding alone, which can be negative on a stress test, will help the cardiologist, gives you a risk stratification and tell you we need to do some prevention before a heart attack comes, and we calculate your risk of heart attack in 10 years. As you heard also, calcium score, you hear it all the time. So what's the difference between that test and calcium score? So calcium score, or CAC we call it, the calcium score is a way to not to go into details and see the vessels, it's just to measure the plaque, how many there is. We don't know if there is a blockage or no blockage, are there plaques outside the heart or inside the heart. It's just a tool to see what's your risks to decide if we need to go further. For example, you have cholesterol, you have high blood pressure, and you have family history, and we don't know if you already build up plaques or not. So the calcium score will let us know, do we change you from moderate risk based on the above information, or if the calcium score is 0 and you don't have any plaque, you become low risk and your risk of heart attack in 10 years will be low. The American Society of Cardiology and the AHA, they have a guidelines that usually entitles calcium score, because based on that calcium score and the calculation we made for your risk to have a heart attack or a major event in 10 years, if it is between 7.5% and above, then we want you to have a medication to prevent or progression, such as cholesterol medication or aspirin. So the calcium score is a way as a risk stratification. Are you a low risk? Are you a moderate risk? Or are you a high risk? To help us know what we need to do. Now, all of this, what I'm telling about CT, is all based on data, and the data was started from Europe initially and now adapted by ACC, also United States. The largest data for coronary CT, we call it ScotHeart data. It's a study done in Scotland, and they took a lot of patients, more than 4,000 patients, and with chest pain. And what they did, now we have the data published in this year in January 2025 in European Journal, and it showed that 10 years follow-up, people with chest pain who were given a CT for their chest pain did much better than people who were just without CT and just regular treatments or prevention with their cardiologist. Because of CT, we were able to detect early the plaque, as I showed you, and based on that, we were able to do prevention before even coming late, because you present late with the plaque, it's already too late. So it showed decrease in heart death, it shows decrease in heart attacks, and even in general strokes and heart attacks in general. So CT is a powerful tool to let us detect things earlier than to present late after a stress test. Now the technology, as I said, went far beyond, and we have something called photon detection CT. Before we couldn't see inside the stent, as this picture below was an old CT, but now with photon detection CT, we can see exactly inside the stents and even the calcium building up on the stents in details, which is sometimes no imaging modality can do that detailed imaging. Now CT also can look in the heart in general, not only the vessels of the heart, and mainly we use the CT without the vessel, we call it CTA non-coronary, to look mainly for a clot or to look for a defect. As you see here, there is defect born, congenital defect in the septum, intraatrial septum, which we call it ASD, and that's born with it and a hole in the heart detected on CT. Now with the plaque, the new technology that, as I said, San Antonio also will have it soon, is mainly not only seeing the plaque, is detecting, which is the big thing, is detecting which plaque will cause you heart attack and which plaque is safe and it's not causing you heart attack. And that's a big thing in medicine nowadays, because in the old days we never knew which plaque will be unstable and cause you heart attack versus the one that doesn't. And now with this modality, it's a breakthrough, because now we can save people's life from heart attack knowing that that plaque is detected earlier. As they said in this phrase, to take the right action, you need the right insight. It's time for a change. Let measures heart disease, not surrogates. So we don't want to do like the flow, like nuclear studies and before. Now we can see the plaque and tell you which plaque. And this is an example. They correlated IVUS, which is an ultrasound inside your vessels to see the plaque, versus that CT with AI, with artificial intelligence to detect the plaque. And it correlated to the IVUS in the same degree with a high accuracy. On top of that, the accuracy reaching 95%, detecting the core of the plaque, meaning the plaque that has microcalcification or the plaque that have soft tissue and not a lot of calcium. This plaque is high risk to rupture, and now we can detect it with CT and AI help. On top of that, there's new things coming also. Some CTs now, it's still into the studies and coming later, we can detect even the fat around the vessel, and inflammation in the fat, depending on how much inflammation the red is, will give you risk that this vessel is diseased and will form more plaques before even the plaques appear. So that's still in the research studies, mainly regarding that fact. Another thing that's also established that we have is measuring the flow. So meaning how much the flow is in each vessel, and we can measure the flow kind of physics of hemodynamics flow and know which plaque is causing limitation of the flow and need to be fixed. And that's helped a lot the interventionalist to decide which plaque need to be fixed versus not, without even invasively looking, going inside and doing these testing. So in a nutshell, kind of looking at this, in a nutshell, we have a lot of information we can give by CT now with AI help and flow AI generation. We can detect the number of the plaque, the volume of the plaque, is the plaque unstable and can cause heart attack, how is the plaque flow or the flow in the vessels due to the plaque is affected or not, and all of those, and the stents as I showed you before. So a lot of information on CT that can prevent heart attack, and that's what we wanted a long time ago, and I think the future is coming for CT, and to see in details which vessels we want to fix, as labeled here in red, which vessels we need to monitor in details and do prevention for each patient. To change subject from cardiac CT, we'll move a little bit to cardiac MRI. Cardiac MRI is a tool a lot of people don't know about. It's a safe tool. The contrast, a lot of patients ask me about contrast with MRI is different than the contrast with CT. It's not related. It's a safe contrast. The recent publication from New England Journal showed that contrast can be used in even kidney disease with no problem with the new contrast. MRI, I like to call it one sentence. I like to call it one stop for cardiologists, like one stop shop. So meaning you can see a lot of things in one study only. You don't need multiple studies for multiple questions, except in one study you can see all. This is an example of cardiac MRI, people who didn't see it. You can see the heart moving. This is a congenital disease, a patient with only one chamber in the heart instead of two chambers on the lower chambers, or a single ventricle, we call it. And unfortunately, everything that should be separated is not, with only the upper chamber separated. And this is the gold standard for congenital disease is MRI. Now, MRI, as I said, is one-stop shop for cardiologists because we can see multiple things. We can see the function in details and very accurate compared to echo for only function. We can see even the tiny vessel obstruction if it's affecting the muscle, and we can see that black thing on top of the white, which is the scar. The black is the normal muscle, how it looks in MRI, and the white is the scar, and that black is the tiny vessel obstruction, which is also only MRI can show. You can do a stress test while doing in the same MRI, and we can see the edema or swelling, what we call it, when you have an infection in the heart, and we can see the scar to decide is the muscle is dead or it's still viable, we call it, meaning it still can be viable, and if we do therapy, the muscle can come back to its usual state. So in MRI is the vast information that each category, as mentioned in this picture, will help in our management in your disease. Another illustration, as I said, we can see the clot, the valve. We can see even rare disease like amyloidosis, sarcoidosis, or hemochromatosis, which is all, we call them infiltrative disease, meaning they deposit toxic substance inside your muscle. And that's the only way to see inside your muscle what's going on. A lot of my colleagues use the images, as I said, in MRI for their specialty, interventional electrophysiologist, cardio-oncology, even the oncologist. We do cardiac MRI, and we do also echo, and I will talk about it. The congenital specialist colleague, and the heart transplant or heart failure. So MRI is a very crucial if you have one of those kind of diseases, as I said, oncological disease or any congenital disease. This is a new technology that we call it mapping, and it's still developing. Even without contrast, we can see the scarring and the swelling and how much scarring there is in the heart. And we can define if you have problem with iron problem and you're born with deposit iron in your liver. We want to make sure the heart is not deposit iron, and you can see that black low mapping, we call it, indicates iron deposit in the heart. The edema, you have no edema when you have the iron, and we can also detect how much the iron is in the heart to cause heart problems, and that's very important in that disease. Rare diseases born with, like Fabry disease, myocarditis common, like with viruses, and you come with heart failure or pain in the heart, kind of pain in the chest, or inflamed heart, and you can see the inflammation. We call it T2 mapping, which is that yellow, clear yellow on the orange background. So a lot of information can be with MRI that a lot of modalities cannot see, and that's very important. And even for heart failure, for our colleagues, when somebody have a weak heart and we don't know what's going on and what's the cause of the heart failure, MRI is the first option to know what caused you the weakened heart, so we can detect what we need to do. And that's also very important. When they do pathology on each disease, and that's what's beauty about MRI, we can see inside the tissue characterization that we say in medical term, to see if your heart is a normal inside the tissue, or there is other causes like inflammation, as I said, amyloid, which is the toxic substance deposit, iron deposition in blue, and then all of those other diseases that's mentioned. To go back to nuclear medicine, the new in nuclear and is the PET scan. The PET scan, you heard, most of you hear about PET scan in oncological field or hematology or assessment of a mass or a spread of a cancer. But PET scan also can be used for heart disease. So, and the most important thing that usually we can measure in PET scan that other modalities cannot measure is what we call it coronary flow or microvascular flow. Meaning, I just showed you that the heart has 3 big vessels, but the heart has even very, very tiny vessels to each segment, but we cannot see on any test. I showed you an MRI, we can see some signs of that microvascular obstruction, but in PET scan we can measure it and see if it is low or not. And some people have chest pain all the time and they do all the testing and it's negative, except when you do the PET and catch that coronary flow or microvascular, especially in women mid-age, and it turned out to have microvascular disease, and there is a specific treatment for it, and that can cause the chest pain, and nobody knew for a long time. I have a lot of patients that spend like 1-2 years, nobody knows why they have chest pain until we diagnose the microvascular condition. The tiny vessels are blocked, not the big vessels. Another condition called cardiac sarcoidosis, and just a nutshell what it is, it's a inflammation. We don't know the cause. Some theorize because of an infection, some theorize autoimmune, but it's an inflammation, your immunity attacking your heart and other organs, lungs and other stuff and joints, but it attacks the heart. And to detect that inflammation and follow it, meaning when we give you medication for that disease, we need to follow to see if it is working, and the PET scan is one of the best tools to follow cardiac sarcoidosis, to see is the inflammation progressed or not, or if there is other condition that the heart is now fibrosed and it's not working and there is no more inflammation and it's a dead tissue. So PET scan, let me know, should I change my therapy, things are progressing or not, and that's kind of what it helps us to know.